start. I'll do HIV primary care for y'all. So what is HIV? We all know that HIV is a virus that damages the immune system of people that it infects. And unlike most viruses, HIV cannot be cleared by the body. So once they become HIV infected, the person has HIV for the rest of his or her life. All right, so where did this HIV story, begin? Well, in 1959, an adult male died under strange circumstances somewhere in Africa, and what is now known to be called the Democratic Republic of the Congo. His blood was frozen and later tested, and he was found to be HIV infected. So 1959, right, this is the first known case of HIV infection, although discovered retrospectively. In 1960, a lymph node taken from an adult female, also from that Democratic Republic of the Congo, was found to be HIV infected also. And in 1960, Jerome Horwich of Wayne State University School of Medicine, he synthesized azithromycin under a grant from the US NIH. Azithromycin was intended as an anti-cancer drug, though it didn't work so great as an anti-cancer drug. In 1969, HIV was found in tissue samples from an American teenager who died in St. Louis. And in 1976, HIV was found in tissue samples from a dead Norwegian seal. Now, the real story of HIV really began in 1981. And in 1981, all right, this is when the real story with HIV began. The first cases of a new immunodeficiency disease was diagnosed in gay men in California and New York. These gay men had Kaposi sarcoma and pneumocystis pneumonia. And in those days, because it was only present in gay men, they called it gay-related immune deficiency, or GRID. But then later on, in 1981, this immunodeficiency disease was also diagnosed in injection drug users. And then in 1982, the immunodeficiency disease was reported in several European countries. But we can't call this thing GRID again, gay-related immune disease. So in 1982, the disease was named AIDS by the CDC in USA and SIDA in France and Spain. And then in 1982, AIDS was reported in hemophiliacs and Haitians. Now, in 1981, when this immunodeficiency disease was found in gay men, the purists in society were saying, well, someone up there, the Almighty, sent down this plague, to kill out all the gays. And then when they also found it in injection drug users, it confirmed their suspicion that, some almighty force wanted to, get rid of the gays and the injection drug users. All right, but then when the AIDS was reported in hemophiliacs, that had people scratching their heads because remember, hemophiliacs are part of the normal populations, and Haitians, well, they started saying that AIDS probably came from Haiti in the first place. And you can see here a patient with Kaposi sarcoma, these reddish brown plaques and nodules on the chin and neck and a few on the nose here also. This is caused by human herpes virus 8. All right, in 1988, the health ministers met to discuss AIDS, and they established World AIDS Day as December 1st. So every December 1st now is World AIDS Day. And in 1991, Irvin Magic Johnson announced he was HIV positive. When I asked the medical students, who is Magic Johnson? Nobody could tell me. You all know who is Magic Johnson? In here.
Yeah, he's a basketballer.
Right, a famous basketballer. Good. For the medical students, you're probably a little bit older than them. They never heard of Magic Johnson. And then in 1994, AZT was shown to reduce the risk of mother-to-child transmission of HIV. Now, let me ask you a question. So suppose a woman is HIV infected and becomes pregnant, no medication at all. What is the risk of mother-to-child transmission of HIV in the absence of any antiretroviral therapy? 0, 25, 50, 100%? What do you all think? No antiretroviral therapy. Pregnant HIV positive mother.
50 to 100.
50 to 100. Anybody else?
25.
Yeah, it's actually about 25%. And actually in those days, early days, we were shocked because we really thought, what if this woman have HIV? For sure all the babies would be born with HIV. And in fact, when we actually tested all the babies at birth, all of them were HIV positive. Why? They were all HIV positive when we tested them at birth. So it confirmed to us, well, this thing is 100%. So why were the babies HIV positive when we tested them at birth?
They were breastfeeding.
Yeah, but I mean, we did it sometimes a couple of days after birth, one day after birth, at birth.
No, because they had the mother's antibodies.
Yes,
And
excellent.
they were testing for
Right, the mother's
antibodies.
IgG crossed the placenta and went into the babies. So when we tested them at birth, and we used to tell the mother, oh gosh, your baby HIV infected, and we didn't realize it's the HIV antibodies. But then when you repeat that HIV test again at 18 months, we found that 3/4 of the babies were in fact HIV negative. All right, by that 18 months, the antibodies started to decline and wane. All right. So what they did was they did a study in 1994 where they looked at the drug AZT or zidovudine, and they did it in the US, France, UK, where they had about 400 mothers, and they split them into two groups. 200 of the so 400 HIV positive mothers. 200 of the mothers got AZT, and 200 got placebo. During labor and delivery, the woman who got AZT got IV AZT, and of course the woman who got placebo probably got saline or dextrose water. And then after birth, the babies in the AZT arm got 6 weeks of AZT syrup, and the babies in the placebo arm got 6 weeks of placebo, probably some multivitamin. And then when they analyzed the data, they found that about 25% of the babies who were in the placebo group were HIV infected. And then they analyzed the AZ2 group. It was about 8% were HIV infected. So what you did was you reduced the transmission from mother to child from 25%, so 25 babies in 100, 8 babies in 100, which is huge. So you literally save 16 babies or 17 babies there, right? So as a result of that study, everybody began to use AZT to treat pregnant women, and the infant HIV infections began to fall in the developed countries due to the use of AZT. However, in those days, now, with HIV, you had no treatment. So once you had HIV, inevitably, you progress to AIDS and death. All right, so in those days, if a patient came in with AIDS, AIDS, you'd have a CD4 count less of 200, or you have an opportunistic infection, or the AIDS-defined opportunistic infections. We'd usually tell the patients, well, I mean, you have this illness, we can't really have any medication to treat you. We can treat the opportunistic infections. So, I mean, we recommend, if you want to make a will, now would probably be a good time to make a will. And if you want to determine, how you'd like to be, cremated or buried, now would be a good time to do that. But then in 1996, things changed dramatically. Combination antiretroviral therapy came into being, meaning 3 drugs or drugs from different classes of antiretroviral agents came into being. And this changed the whole landscape of the HIV AIDS now. HIV is now a chronic disease with a life expectancy almost that of the normal population. All right, any questions anybody want to ask on this little bit of epidemiology I gave you all? Now in Trinidad and Tobago, if you all knows Port of Spain Hospital, a young man, 22 years old, came in with weight loss, oral candidiasis. It's like neck stiffness, you know. When they did the lumbar puncture and in the ink stain, it was positive. So he had cryptococcal meningitis. And this was actually the first case of AIDS. He was diagnosed by Professor Bartholomew, Ward 31, Port of Spain General Hospital. All right, so first case of AIDS in Trinidad. 2 years after the cases of AIDS in the US were described. And then, remember I told you that HIV was mostly present among the gays, the gay or bisexual men. So Professor Bartholomew decided, okay, he will do a study of 100 homosexual, bisexual men. So what he did was he designed a questionnaire and he collected a blood sample, all right? They spun it down and they stored the sera, all right? He stored the sera at Carrick. And from the questionnaire, you know, he asked some of these gay, bisexual men how many, you know, partners they had. Some of them had as much as 1,500 partners in their lifetime, and they were actually in the early 20s. So he was shocked. You know, so he said when he was hoping, when he did this study, you know, 100 homosexual men, he thought it might take a year or two. He said in 3 months, he was able to collect his cohort of patients. Anyhow, the HIV blood test became available in 1985. It was developed by Dr. Robert Gallo, and this was one of Professor Bartholomew's collaborators. So once Dr. Gallo developed this blood test, Professor Bartholomew shipped the samples that were stored in Carrick up to the US to be tested. And then the HIV seroprevalence in this group in 1983-84 was 40%, which is alarmingly high. And then the risk factor when they analyzed the data was sexual contact with a North American maid. In those days, they used to have these gay bathhouses in the US, all right, where men used to go in and just have free indiscriminate sex. And the trainees, you know, like anybody else, the gay trainees, because it was highly stigmatized and they were discriminated against if you're gay, they used to go up to the States, all right, and participate in sexual activities in these gay bathhouses. So that was the risk factor. And then in 1985, the whole story changed in Trinidad and Tobago. First cases of AIDS in women and children were diagnosed. And then since 1985 in Trinidad and Tobago, there has been a rapid transition to a predominantly heterosexual epidemic. So right now in Trinidad and Tobago, our epidemic is heterosexual, where the number of males and females are almost identical. And then in 2002, Trinidad and Tobago, the government decided to purchase antiretroviral therapy for the nationals of Trinidad and Tobago. So it became available free of charge to nationals of Trinidad and Tobago. Again, I was trying to get some updated data, and I mean, they don't seem to have, so I just have up to March 2016, and this is the data. But this slide is a little more, could show you how things change in Trinidad and Tobago. So if you all see in here, the purple is the females, the blue is the males, and then the yellow is the total males and females. And you can see the AIDS cases, or you can call it HIV positive, it's actually AIDS cases, started off in the men, in the blue. And all throughout the years from 1983 to 2004, the number of males were greater than females. And then look what happened. The females caught up. So in Trinidad and Tobago, as you can see, 2004 and 2006, we have a heterosexual epidemic. All right, now looking at global estimates, this is UN AIDS figures for 2022, last year. The people living with HIV/AIDS was 39 million. The new HIV infections that occurred in 2022 was 1.3 million, and the deaths due to AIDS was 630,000. All right. So if you look at it, they estimated that about 3,600 new HIV infections in adults and children occurred each day in 2022. About 50% of this occurred in sub-Saharan Africa. 360 among children under 15 years of age. This is of the daily 3,600 new infections. 3,200, sorry, among adults 15 years and older. Almost 46% of these are females. 30% are among young people, 15 to 24. And 18% are among young women, 15 to 24. So we still having lots of new HIV transmissions occurring every day, 3,600 every day globally. Looking at children living with HIV now. Now, I do some work at the Cyril Ross Nursery, which is basically the home that takes care of children with HIV. And I don't think we have gotten a new HIV positive child for the last 3 or 4 years because the PMTCT program, the Prevention of Mother-to-Child Transmission program, works so well. All right. Cyril Ross used to have between 30 and 40 kids. Now I think right there we probably have less than 10 children now living with HIV there. All right. So in terms of the global estimates for children less than 15, globally, the number of children living with HIV is 1.5 million. New infections that occurred in 2022 is 130,000, and deaths due to AIDS was 84,000. All right, so that's among the children. Again, this is really too high because the prevention of mother-to-child transmission programs work really well. And then looking at the regional HIV and AIDS statistics, by regions, all right, you can see that Eastern and Southern Africa have 20.8 million people living with HIV/AIDS. Western and Central Africa, 4.8 million. Middle East and North America, 190,000. Asia and the Pacific, 6.5 million. Latin America, 2.2 million. Caribbean, that's our region, 330,000. Eastern Europe and Central Asia, 2 million. North America, which is like the USA and Mexico and stuff, 2.3 million. So this works out to be 59 million people living with HIV/AIDS. Now, there are 2 different types of HIV, HIV-1 and HIV-2. All right? HIV-2 is found in West Africa. If you have HIV-2, it takes a longer time to develop AIDS, and HIV-2 is less transmissible than HIV-1. So if you're figuring you want to get an HIV, it's probably better to get HIV-2 because you'd probably live longer and it's less easily transmissible. All right? But the HIV-1, all that has changed now with antiretroviral therapy. HIV-1 is divided into M major, N new and O outlier, and P subtypes. All right? And the HIV subtype M, the major, is divided into subtypes A to K. And you can see that subtype B here, which is present in North America and Europe, is also present in Trinidad. And remember, we said that Trinidad, we got much our HIV, the risk factor was sexual contact with a North American male. All right, so if ever there's a vaccine developed, and would usually be developed in North America or Europe, and maybe subtype B, because that is the type of HIV they have, and may benefit Trinidad. But again, antiretroviral therapy works so well that, and I'll tell you more about that later on. And it works against all the different subtypes. So subtype C is in South Africa, Southern Asia, Ethiopia, subtype D in East Africa, and subtype E in Southeast Asia. Now, how does HIV cause AIDS? Now, we have an important cell in the immune system called the T helper cell or the CD4 cell. HIV infects and destroys these CD4 or the T helper cells. The CD4 cells or the T helper cells direct and coordinate other cells in the immune system to fight infections. So when the CD4 cells are destroyed, the body loses its ability to fight infections, and as a result of it, you get all these opportunistic infections. So think of the CD4 cell as the sergeant major in the army. If you take out the sergeant major, this is the guy in the white shirt, he can't perform well. So if you take out the CD4 cell, helper cell, the immune system will function properly, and as a result, you get all these opportunistic infections. All right. Any questions on how HIV causes AIDS? We good so far?
Yes.
All right. What is AIDS now? AIDS is called the acquired immune deficiency syndrome and occurs when the CD4 count is less than 200. Or if a patient is HIV infected and has any of those AIDS-defining illnesses, they automatically have AIDS. So AIDS represents the end stage of the disease, and this results from untreated HIV infection. What is a viral load? Now, I talked about the CD4 count early on, all right? A CD4 count, a normal CD4 ranges from about 600 to about 1400, all right? And when the CD4 count is less than 200, you have AIDS. The viral load is basically simply a measure of the quantity of HIV in a drop of the patient's blood. But in general, the higher the viral load, the faster the CD4 cells are destroyed. All right, I'll probably talk about this thing here. Basically, let me see if I have something to talk about it. Basically, you come in contact with HIV for the first time. In the red here, you can see the virus multiplies in the red here, and reaches very high levels. Now you have two arms of the immune system. You have the humoral arm and the cellular arm. All right? Immune system then kicks in and controls the virus to a certain point. They are called the viral set point. All right? And you can see here, there's a little decline in the CD4 cells here. Also during this phase of multiplication, all right, the patients may develop a flu-like illness. So they may develop fever, sore throat, lymphadenopathy, fatigue, malaise. And if you actually test this patient for HIV in this phase here, the HIV test may come back HIV negative. Why is that? If the patient has millions of viral particles in the blood, and you test it at this stage, HIV test is actually HIV antibody negative. Why is this?
They haven't started to manufacture the antibodies yet.
Yeah, so this is called the seroconversion period. And the HIV antibodies have not been manufactured as yet. So even though the patient may have millions of viral particles in the blood, the HIV antibody test will be negative. All right. So this is the so-called window period. And I'll talk about this later on. All right. And then, as I say, eventually the immune system controls the virus at a certain point called the viral set point. And then the patient usually grumbles along at the viral set point. And then probably about 10 years later, the CD4 count rapidly diminishes, the viral load rapidly increases, AIDS develop, and if the patient isn't treated with antiretroviral therapy, that will intervene. All right? So think about a train heading towards a cliff. All right? The distance of the train to the edge of the cliff is the CD4 count. And the speed at which the train is traveling is the viral load. So suppose you start a patient on antiretroviral therapy. Tell me what's going to happen to the train. Anybody?
It'll slow down.
Right. So what you do is you suppress the viral load. The train will slow down. Then you'll stop the train, all right, and put it into reverse. And the CD4 count will start to increase. So that's how antiretroviral drugs work. So for many now, HIV is no longer a death sentence. At best, HIV is analogous to diabetes, all right? With all the complications of diabetes, you have the microvascular and macrovascular complications, all right? So kidney disease, eye disease, peripheral neuropathy, etc. If you manage the diabetes quite well, you delay those complications, all right? Similar to HIV, you manage the HIV, all right? You prevent the patient from developing complications. Once a person starts antiretroviral therapy, it takes probably 2 to 6 months for the viral load to become suppressed or undetectable. That's undetectable means untransmissible. U equal to U. Tell me what that means. Undetectable means untransmissible. What does that mean? All the patients will tell you that. Doc, U equal to U.
It means that once the viral load is undetectable, like less than 1,000 copies, but if it's undetectable, they're unable to transmit the HIV, even if they have an unprotected
Right.
intercourse.
Excellent, excellent. So once the viral load is undetectable, there's no transmission of HIV to the sexual partners. Now, that has raised a hornet's nest in itself because now all these patients say U equal to U and they stop using condoms because they ain't transmitting HIV again. So I have quite a few discordant couples, one positive, one negative, and they stop using condoms, U equal to U. Never seen any of them become HIV infected, but I mean, U equal to U, basically. All right. So just to show you what U equal to U is, this was a patient from Haiti, and you could see he was on a fast train heading towards disaster. Started him on antiretroviral therapy, and here is he 1 year later. All right, so again, antiretroviral therapy really works for us. Now, what are the secretions associated with increased risk of HIV transmission? Well, we know blood and blood products, and male and female genital tract secretions, and breast milk. All right, we know those. Also, HIV-infected blood donors. Now, there are other body fluids, for example, pleural, pericardial, peritoneal, synovial, amniotic, and CSF. They also carry a higher risk of HIV transmission, but it's never been quantified. So again, you come in contact with those body fluids. Make sure you protect yourself. You wear masks and gloves and stuff. All right. Things like urine, saliva, tears, sweat, feces have little or no risk of transmission of HIV unless it's bloodstained. All right. So urine, saliva, sweat, tears, feces, little or no risk of transmission of HIV. And HIV was described in 1981, so I mean, the epidemic is 40 plus years old now, so I mean, we know quite a bit about it. How do you prevent HIV? Abstinence, no sex, no HIV. Fidelity, if you have one sexual partner, both they all test before, probably wouldn't get HIV. Consistent use of condoms, condoms work very well. No sharing of needles. Luckily, in our part of the world, people not injecting no heroin or anything, It's not in the cocaine, so you don't have any problems with needles. You must test all blood and donated organs for HIV, which is what we do. We test all pregnant women for HIV. All right. We give the mother antiretroviral therapy if they're HIV infected, and we give the baby antiretroviral therapy. And the government of Trinidad and Tobago gives free formula milk to all HIV-infected mothers for a year. So we don't allow our mothers to breastfeed the babies. All right. So if you do all those things, you can prevent HIV transmission. All right, I also went through this with you all already, talking about the viral set point and stuff. And I told you during the acute phase, yeah, you may get a febrile illness, a seroconversion illness. It's called primary HIV infection or acute HIV infection. It occurs usually within 2 to 6 weeks after HIV enters the body. All right, and it presents with a flu-like illness with these symptoms. All right. Now, if you want to diagnose a patient with acute infection, how would you make this diagnosis? So I had a patient once, a gay man, who came to me because he had all these flu-like illnesses. Because he was gay, his general practitioner did a HIV test on him and he was HIV negative. All right. But he came to me because these symptoms persisted, sore throat persisted, even though he was on augmentin by his GP. All right. So he came and said, Doc, I don't know what happened. I have these symptoms for the last 2-3 weeks now, and are HIV negative. And what happened? What do you think happened with him? Nowadays, that was about 10 years ago. Nowadays, we'd say, boy, we probably have to do a test for COVID for you. What do you think happened with this man?
He was in a window period.
Yeah, he was in the window period. So how do you make a diagnosis of HIV then in the window period?
That's a PCR, but it's
Is
something we would
PCR?
do.
Yeah, exactly. So what happened was, I say, tell him, I say, listen, I have to run a special test for HIV. He said, but doc, I have no HIV. Look at my HIV test results. Yeah, anyway, you know what? All your doctors and shit, I can't diagnose what I have. I traveling to the States tomorrow. Is that right? Okay, thanks for your services, I got. I said, all right, no problem. So 2 days later, I got a call from a colleague of mine who went to school in Fatima with me. He said, hey, doc, I have your patient here. So what do you think happened with him? He told me he need to do a special test. What test should he do? Imagine he asked me that. I said, well, do a HIV viral load on him, the PCR test on him. He said, all right. He called me back 2 days later. He said, doc, your patient viral load is 3 million positive. 3 million copies from now. So what I'll do, I'll go ahead and start him an antiretroviral therapy and send him back to you. So that's what he did. Started him an antiretroviral therapy and sent him back to me. Came back home probably about 4 or 5 weeks later. I repeated the HIV antibody test, and the HIV antibody test was HIV positive. So he actually seroconverted. All right. So this was a case of acute HIV infection. So if you all were accident and emergency, although you're thinking COVID, if the patient have risk factors, you probably would want to do a PCR test. All right, so let's look at the events in HIV, early HIV infection. So the first thing that becomes positive is the HIV RNA, hence you can do a PCR. All right. Then the patient may develop symptoms. And another thing that becomes positive quite early is the P24 antigen. So if you've done a P24 antigen on this patient, it will also been positive. And then from about 2 to 4 weeks, you start slowly getting antibodies. But even though they're starting to produce them, it has to reach a threshold for the antibody test to become positive. And with the new antibody test, you can usually get this within 2 to 4 weeks. All right. So again, just to show you time course of the HIV test, the HIV RNA comes positive, the P24 antigen, and the symptoms, and you can see here, in 3, 4, 5 weeks, the HIV antibody test becoming positive. So to diagnose acute or seroconversion illness, you have to use to diagnose the HIV RNA, a PCR, you can do the P24 antigen test. All right, any questions? So, diagnosis of acute HIV infection, the HIV antibody test will be negative, but the HIV DNA or RNA or the PCR will be positive, or the HIV antibody test will be negative and HIV P24 antigen will be positive. So that's how we diagnose acute or primary HIV infection. All right, and I went through this already, telling you how the typical progression for HIV/AIDS. All right, I told you here, this is the set point. Now, there's a thing called long-term non-progressors or elite suppressors. Some people, very few, people are quite fortunate in that their immune system can control the viral load to very low levels, undetectable. Our machine could go up to less than 40. Yeah? So undetectable doesn't mean zero, it just means that the machine goes to less than 40 copies per mil. So some fortunate people, their immune system can actually control the virus to low levels, undetectable levels, and they're called long-term non-progressors or elite suppressors. All right. They found that when you, this may actually last quite long, but they found that when you follow them for 10, 15, 20 years, the viral load starts rising. I mean, it's quite controversial whether you want to put these patients on antiretroviral therapy because the viral load already suppressed. But again, it's controversial, but I would actually put the patient on antiretroviral therapy because even though you have low levels of HIV in the blood, you still have HIV multiplication taking place, and this is associated with inflammation. I'll talk about it later. All right, so these are elite suppressors or long-term non-progressors. Then you have the unfortunate persons who can't control the HIV virus. And the viral set point is way up here in the millions. We actually had a patient who was HIV negative, seroconversion, and he seroconverted and died within 6 months of seroconversion because he wasn't able to control his virus. All right? We actually wrote up that case. So this is rapid progression. So you need to start antiretroviral therapy as soon as possible in these patients. By the way, when do we start antiretroviral therapy in patients with HIV? And what CD4 count?
At any CD4 count. Once
Very
they
good.
diagnose that.
Right, we start antiretroviral therapy as soon as they diagnose. Why would we do that? We do that for two reasons: a public health reason and another reason. Why we do that? Why we start
Probably
them
to
as soon
help
as they
with
diagnose?
transmission. To stop
Right,
transmission.
so excellent. So, because once we put them on antiretroviral therapy, suppressive viral, they no longer transmit HIV sexually. In addition, once you start antiretroviral therapy, the life expectancy is normal also. So, I mean, you know, so that's why you want to start antiretroviral therapy as soon as possible. So I didn't trick you all with the CD4 count thing. Good. Now, how do you test for HIV? Well, they have these algorithms, and I'll show you the algorithm now. This test here is called the Determine test. It's made by Abbott, so Abbott Determine. So what you do, you put a couple drops of blood, you can actually do a finger prick on the strip here. There's the test here, the rapid test kit. Drop a couple drops of buffer and sit and wait. Just like a pregnancy test, 2 lines is positive, 1 line is negative. You get a result in 10 to 15 minutes. All right. Now, our algorithm in Trinidad and Tobago, if the test is negative, you can report the patient is negative. If the test is positive, we go one step further. We repeat it using another rapid test. This test we use is a Uni-Gold test, which is another rapid test kit. All right? If the 2 tests are positive, the Determine and the Uni-Gold, you can report this as positive. If 1 test is positive, the Determine is positive, and the Uni-Gold is negative, then you need to repeat another test, and they would usually do ELISA or they would do another test. All right? So the algorithm, this was the old algorithm in the Ministry of Health. Let me show you the new algorithm. The new algorithm states that you have a blood sample now, you do a test, you rapid test to determine. If the determined test is negative, the patient is negative. If the determined test is positive, you do another rapid test because you want to make sure. All right? So use a Uni-Gold. If the Uni-Gold test is positive, the determined test is positive, all right? You report this as HIV positive, all right? If the Uni-Gold test is If the determined test is positive, the unical test is negative, then we do a ELISA. All right. If the ELISA is positive, the report is positive. The ELISA is negative, the report is negative. All right. So, but all positive samples go to public health lab and they do a confirmatory ELISA on it. And 1 in 10 negative tests go to public health lab for them to do a confirmatory ELISA, all right, for quality control. All right, so any questions with the algorithm? This is the rapid test algorithm that we use right in Trinidad right now.
I have a question.
Sure, go ahead.
If the person is viral load is suppressed, just out of curiosity, would the
No.
antibody...
So that's it. Remember, the viral load is a different. You're measuring the virus.
Yeah, I know.
Antibodies is a
If
different thing. So even though the
was...
patient is virally suppressed, the antibody is always positive.
All right.
All the
Okay,
patients access that. So doc are undetectable now, but HIV test could be negative. I tell them, unfortunately, no. You know?
Yeah.
Because it's two different things we measure. Measuring the virus by the PCR, we measure the antibodies, all right, but these ELISAs and rapid tests. All right. Any
Thanks.
questions again on the algorithm?
One question, not pertaining so
Sure.
much to the algorithm, but do you think, just to recap the testing methods, you said PCR was almost immediate detection. The antibody would be positive around 3 months, and the P24
Well,
antigen
from
was
about
24
the
weeks.
newer test, from about 2 to 4 weeks onwards with the newer test, because they have an antigen antibody test they can do now.
That's the P24.
Yeah, it does the P24 and the antibody test now. There's a new test available that does that. So you can actually
Thanks.
cut down that window period. But the
Thanks.
ones, we don't really have that in Trinidad per se. The ones we have in Trinidad is this determined and unigoal. Yeah, and this is usually positive probably about 2 to 4 months after. So if the patient has high risk factors, you can either tell them come back in 3 months to repeat the antibody test. All right.
Thank you.
All right, and this is the 4th generation HIV test I was telling you about, where you look at the P24 antigen and the HIV antibody test. All right. And it detects 95% of infections at 28 days after exposure. All right. And more than 99 point, almost 100% at 3 months. Okay. So you can do this 4th generation test about 2 to 3 weeks after exposure. It has a P24 antigen in it. You don't have that in Trinidad available yet. In terms of HIV classification, the CDC classification, it basically goes on the CD4 count. So if a CD4 count is less than 200, you have AIDS, all right? Whether you're symptomatic or not. CD4 count less than 200, all right? And there are a number of AIDS indicator conditions here. See here. So if you're HIV infected and your CD4 count is 500 and you have an AIDS indicator condition, you also have AIDS, all right? So once you have an AIDS indicator condition, you also have AIDS. So CD4 count less than 200, with HIV infected and have an AIDS indicator condition, you have AIDS, all right? And these are the AIDS indicator conditions. Well, I'll show you. These are not them. Just to show you the correlation of HIV count with CD4 counts, HIV complications with CD4 count. If the CD4, remember I tell you CD4 count usually ranges like around 600 to 1400. So if it's above 500, again, you would get candida vaginitis, you know, all these conditions. When the CD4 count drops now, between 200 and 500, you start to get all these bacterial pneumonias, TB, you know, oral candidiasis, Kaposi sarcoma, zoster. And you're also at risk for certain cancers because of decreased immune surveillance. So you may get cervical cancer, which is the AIDS-defining illness, lymphomas, you know, Hodgkin's lymphoma, etc. And then once the CD4 count is less than 200, you start getting all these AIDS-defining conditions. So histoplasmosis, extrapulmonary TB, toxoplasmosis, cryptococcal meningitis, you know, CMV, you know, Mycobacterium avium, all these conditions, primary central nervous system lymphoma, all these conditions are AIDS conditions. All right, so here are the AIDS defining conditions, meaning that you have any, if you're HIV infected, you have any of these conditions, you automatically have AIDS. All right, and you can see cervical cancer here. You can see herpes simplex. If you have a herpes simplex ulcer for greater than a month, all right, and HIV infected has also AIDS defining condition. All right, so quite a number of conditions here. So there are a number of AIDS-defining malignancies. Remember I tell you there's decreased immune surveillance. So the AIDS-defining malignancies are Kaposi sarcoma, caused by what?
Herpes, AIDS.
Herpes virus 8.
Right, human herpes virus 8. A lot of the non-Hodgkin's lymphomas may be caused by the Epstein-Barr virus. Cervical cancer caused by what?
HPV.
HPV.
PP.
Right, HPV, 16, 18, all those things up there. And primary central nervous system lymphoma is associated with the Epstein-Barr virus. So these AIDS-defining malignancies tend to be usually associated with some viruses. Now, you also have non-AIDS defining malignancies. We find that patients with AIDS have a higher risk of these malignancies compared to the general population. Anal cancer, 50-fold increase. Hodgkin's lymphoma, 17-fold increase. Hepatocellular carcinoma, 5-fold increase. And lung cancer, 3-fold increase. Note things like breast cancer, prostate cancer, colon cancer, is not increased in HIV positive persons compared to HIV negative. So in terms of the non-AIDS defining malignancies, anal cancer, Hodgkin's lymphoma, hepatocellular carcinoma, and lung cancer. They found actually that, I don't know, in terms of hepatocellular carcinoma, some of the HIV patients may be co-infected with hepatitis B and hepatitis C, and that increases the progression to hepatocellular carcinoma and cirrhosis and stuff. And they found that a lot of HIV patients smoke more than the general population. I don't know if that may trigger increased risk of lung cancer. All right. So somebody comes into you and they say, Doc, HIV positive, what do you do? Well, I found lots of patients come from outside labs with an HIV positive result. Repeat the test on HIV testing negative. We're not too sure that all the labs have good quality control, so I would generally repeat all the HIV test results, all right? And in primary care, you take a complete history and physical, do all the regular bloods. Of course, you have to do a CD4 count and a viral load. If you come from a first world country, you do a resistance testing, all right? And you'd assess the readiness of the patient to start antiretroviral therapy and stress that, you need to take your medication, don't miss any doses. And then, depending on the situation, you can do other tests, screen for syphilis, do a MAN2 test for tuberculosis, chest x-ray, screen them for hepatitis A, B, and C, screen for sexually transmitted diseases. All right. They have some nucleic acid amplification tests the government had, hopefully they'll get back again. The same machine that does the HIV viral load also does the PCR for a lot of the sexually transmitted diseases. You just have to get the kits, all right? Remember, cervical cancer is an AIDS-defining illness, so you need to do a pap smear on the patients. CMV retinitis since occurs CD4 count less than 50, so any patient who have a CD4 count less than 100, you refer them for ophthalmology. Screen them for toxoplasma. By the way, where you got toxoplasma from?
Cats.
Cats, and where again?
Cats.
From the soil, if you're gardening, house.
Yeah, you get it if you're in the soil gardening and stuff, but even bigger than that, where do you get toxin from?
Each other.
Huh? Didn't you?
Other people.
Cows?
No way you get it. You go to your favorite restaurant and say, I want my steak,
Or
rare,
undercooked meat.
undercooked meats. All right, that's where you got a lot of the toxin from. And in some thing, actually, I think they did some studies in the US, and 20 to 50% of the population have antibodies to toxin. All right. HTLV1. What do you all know about HTLV1?
It's associated
The
with
T cell.
And go ahead, let me hear listening. Go ahead, who is talking? What does HTLV1 stand for?
Human T-cell lymphotrophic virus.
Yep, human T cell lymphotrophic virus type 1. All right, how is this transmitted?
Much like HIV, bodily fluids, so you can get it from intercourse.
Bodily fluids. You know, any type of bodily fluids are telling you urine, saliva, sweat, etc. Yeah, be a little more specific than bodily fluids.
So you can get it from blood. You can get it from
Blood,
blood.
yeah.
So it's one of the viruses screened for in donor
Excellent.
blood.
When you screen, and yeah, when you screen blood, they screen for that, yeah. Where again you can get it?
Intercourse. So
Yes,
Yeah.
And breast milk.
breast milk.
breast.
Actually, the major mode of transmission of HTLV1 is in breast milk. It's also transmitted via blood and blood products, and also by sexual intercourse. Now, HTLV1 is endemic in certain regions. It's endemic in Africa, South America, Central America, Japan, the Caribbean. And Professor Bartholomew postulated that HTLV1 came to the Caribbean via the African slave trade. How he came to this conclusion? He did a study of food handlers, you know, those people who go for the food badges, you know. He was checking the hepatitis B prevalence, or hepatitis A and B prevalence in those food handlers. I think he had like 1,400 of them. And he stored the sera. And then with this stored sera, he decided, okay, let me test it for HTLV1 antibodies. And when he tested it, the prevalence was about 2.4%. But then when he broke it down by race, he found in the Afro-Trinidadians, it was 3.2%, and the Indo-Trinidadians, it was 0.4%. So he concluded that HTLV1 probably came to the Caribbean via the African slave trade. It is endemic in Trinidad, as I said, it's about 2.4%. All right. What diseases does HTLV1 cause?
T-cell lymphoma and leukemias.
Which T cell lymphoma? Agree T cell lymphoma. What T cell lymphoma though? Anybody? I could see earlier from the younger generation when we used to be Professor Bartholomew, because he studied HTLV1. All of us had to know HTLV1. So it causes adult T cell leukemia lymphoma. It causes a neurologic condition called tropical spastic paraparesis, or TSP. You all ever heard of tropical spastic paraparesis? Anybody? No? It also causes uveitis, and the Jamaicans were first to describe a skin condition associated with HTLV1 called HTLV1 associated infective dermatitis. All right? So if you have final exams and you have some Jamaican examiners and they talk about HTLV1, they're very proud that HTLV1 was described by Jamaicans. So nice to tell them that, you know, Jamaicans describe HTLV1 associated infective dermatitis. Now, remember I told you that HTLV1 is also common in Japan. what the Japanese do, all pregnant women, they screen them for HCV1, and if they are, in fact, HCV1 positive, they don't allow them to breastfeed, they give them free formula milk. All right? All right, in terms of treatment goals, well, we can't eradicate HIV with the antiretroviral agents available because there's a pool of latently infected CD4 cells, which is established early in acute infection, and this persists with a long half-life. So the early establishment of this reservoir, which is still seeding, means that HIV eradication is difficult, if not impossible, all right? Because these CD4 memory cells and other reservoirs, they maintain the replication competent population of HIV for long periods of time. So they have very long half-lives. So we can't eradicate HIV. But we can control HIV. So in terms of therapy, the goals of therapy are maximal and durable suppression of the viral load. You want to restore or preserve the immune function. You want to improve the quality of life. You want to reduce HIV-related morbidity and mortality. Of course, to do this, you have to maximize adherence. So persons shouldn't miss any doses. You should rationally sequence your medication. So if somebody develops resistance to one, you have others. We have lots of antiretroviral drugs, and they preserve future treatment options. And then we use resistant testing, if somebody's feeling better. Actually, Barbados does resistant testing, Jamaica does resistance testing. Don't know how come Trinidad doesn't do it. We actually ship our samples to Puerto Rico for resistance testing. So HART means highly active antiretroviral therapy. This should be initiated as soon as possible after diagnosis, as you all mentioned. And these patients should become, you need to talk to them and say, listen, I take this for the rest of your life. All right. By the way, how many pills is a HART regimen? When I told you that antiretroviral therapy came into being for the first time in 1996. And in those days, people used to have to take 15 to 20 pills a day. How many pills nowadays make up an antiretroviral drug regimen? Anybody? How many pills the patient have to take?
You can be taking one pill a day with 3 medications.
Yes, you're correct. Actually, one pill a day. So a lot of the regimens are 1 pill or 2 pills a day. So you reduce the pill burden, all right? And as a result of that, you maximize adherence. People can't take 15 to 20 pills a day, all right? Of course, you try to see what potential barriers people could have to antiretroviral therapy. Give me some barriers. Let me see if you can figure out what potential barriers people might have. They want to start medication, but they have some barriers that might affect them taking the medication. Give me some.
They don't want relatives at home to know that
Yeah, they want relatives at home to know they're taking medication.
They work
Yeah, they want
hours.
people in the workplace to know. So I usually tell them, listen, put this medication in a vitamin bottle and you should be fine. Hopefully nobody wants to take your vitamins at home, Also, they don't want their sex partner to know that they're taking medication. Sometimes they're disclosed to the sex partner. So they want to know why they're taking medication. Of course, we encourage them to bring in a sex partner, but again, we use the same vitamin bottle story. Other barriers, any other barriers anybody could think about?
Side effects.
Yeah, side effects, correct. If you get all kind of side effects, you ain't going to take this medication. Drug and alcohol abuse. If you have drug and alcohol abuse, or your socioeconomic conditions, if you can't get food, where next meal coming from. That is not your priority. Your priority is getting the next meal, not your antiretroviral therapy, And then you have some things like clinic and thing, if you come to clinic and waiting for 5 hours, all these things, So we try to, get patients in and out of clinic as fast as possible. Now, remember I told you that even though you may have these long-term non-progressors or elite suppressors, and they suppress the viral load below the limit of detection, they may still have this unchecked HIV viral replication going on. So I still like to put them on antiretroviral therapy because this unchecked HIV replication is associated with T cell apoptosis and immunosuppression. The unchecked HIV replication is associated with inflammation and coagulopathy, and you all know this inflammation causes all sorts of things. So this causes non-AIDS morbidity and mortality. So inflammation associated with heart disease, liver disease, renal disease, osteoporosis, malignancies, and neurocognitive decline. So it's probably better to put them on medication than to have somebody, not on medication. Because in addition to getting AIDS-defining conditions, you can also get non-AIDS-defining morbidity and mortality. All right, so in terms of the benefits of antiretroviral therapy, I mentioned that already. Decreased transmission, normal life expectancy, and you maintain a higher CD4 count, so you don't get all those opportunistic infections. And just to tell you, we have lots of drugs available in the different classes. NRTI means the nucleoside reverse transcriptase inhibitors. NNRTI is the non-nucleoside reverse transcriptase inhibitors. The PIs is the protease inhibitors and the integrase inhibitors. So antiretroviral drug regimen will consist of 2 NRTIs here, this class here, and any one from any of these classes. All right, so 2 NRTIs, and what we usually use is tenofovir plus M-tricytabine or tenofovir plus lamivudine, and any one of these. Long ago, we used to use tenofovir plus M-tricytabine plus efavirenz, and this was combined one pill called atripla with a whole heap of side effects. We used to combine them with the protease inhibitors, but nowadays we're going with the integrase inhibitors. I'll give you the story with the integrase inhibitors on Trinidad. All right. Now, our combination that we had, the 2 NRTIs, tenofovir plus M-tricytabine, and efavirenz. Efavirenz is associated with a whole heap of neuropsychiatric side effects. So you get dizziness, so the patients have to take it in night, they get strange dreams, they get difficulty in concentration, they get increased risk of psychiatric problems and suicide, they get sleep disturbances, very rarely they could get a rash. Tenofovir is associated with renal impairment and bone mineral density abnormalities, so osteoporosis. M-tricytabine is fairly benign, and I get a little nausea and stuff like that, all right? But efavirenz. So this is our first line regimen here. You see the problem with efavirenz, but usually in most patients, once you ride their way through these side effects, usually by about 2 weeks, they would disappear totally and they can tolerate it. Some people can't tolerate it and we have to switch them to another regimen, all right? Nowadays, the integrase inhibitors are in vogue. They have minimal side effects. They rapidly reduce the viral load, all right? So usually combine dolutegravir or bictegravir with tenofovir and M-tricytabine and 1 to 2 pills a day. Or you can use dolutegravir plus abacavir plus lamivudine, so that's what the first world countries usually do. All right, I'll tell you our story in a bit. So if you want to pick an initial treatment regimen, all right, you should be guided by the efficacy, all right, how quickly to reduce the viral load, toxicity and pill burden, the dosing frequency. So you prefer minimal side effects, 1 pill once a day, any drug-drug interactions, the resistant test results, comorbid conditions, access and the costs. And as I mentioned to you, the recommended regimens in the US, in Europe, is the 2 NRTIs plus an integrase inhibitor. All right? That's what the preferred thing is. The PI used to be there, but now this is taken off. So the preferred regimens now is just the two NRTIs plus an integrase inhibitor, all right? But again, you could use any of these regimens, all right? But the preferred regimen is the two integrase inhibitor and the two NRTIs. Unfortunately, we still have to use the NNRTI plus two NRTIs and the PI plus two NRTIs. I mentioned boosting of the protease inhibitors. Why do we boost it? So what we usually do is give a protease inhibitor. So I'll just call a name for atazanavir, and you boost it with another one, a small dose of another one called ritonavir. So you give atazanavir with a small dose of ritonavir. All right? Protease inhibitors are metabolized by the P450 liver enzymes. And ritonavir is a potent inhibitor of the cytochrome P450. All right? So if you give a small dose of ritonavir with a protease inhibitor, what it'll do, it'll inhibit the cytochrome P450 and decrease the metabolism of the other protease inhibitor that you co-administered with it. All right, so what this does here, reduce the pill burden. Yeah, lengthen dosage intervals. For example, you could do TDS to BD or OD. You have a potential to overcome HIV's drug resistance. So boosted protease inhibitors have a high genetic barrier to resistance. But unfortunately, because of the effect on the cytochrome P450, they're potentially dangerous or fatal interactions with other medications. All right, so with the protease inhibitors. So we don't like to boost too much because of the interactions. So that's why the protease inhibitors are no longer preferred because of these interactions. So the preferred 2-NRTI backbone, remember I told you, tenofovir or emtricitabine or tenofovir plus lamivudine, or you could use abacavir plus lamivudine. Now, abacavir is associated with a hypersensitivity reaction. So there's a test you can do for it, HLA-B5701 test. If this is negative, then the patient will be unlikely to develop the abacavir hypersensitivity reaction, and he can use abacavir. Fortunately, it's uncommon in people of African and Indian origin, more common Caucasians. We don't have that HLA-B5701 test. So, I mean, we do give abacavir. I don't think I've ever seen a abacavir hypersensitivity reaction in our patients. All right. In terms of the recommended initial regimens, is the US guidelines. The protease and the integrase inhibitor bictegravir plus tenofovir plus emtricitabine, or another integrase inhibitor, dolutegravir plus abacavir plus lamivudine. Remember, if you're using abacavir, you have to test for HLA-B5701. And if you're negative, you can use it. Now, tenofovir plus emtricitabine, especially the tenofovir, if the patient is co-infected with hepatitis B, the tenofovir and the emtricitabine treats hepatitis B. All right, so you don't want to give dolutegravir plus, abacavir plus lamivudine in persons with chronic hepatitis B, because tenofovir is an important drug for treating chronic hepatitis B. You can also use dolutegravir plus tenofovir plus emtricitabine, and they've recently come up with a 2-drug combination, dolutegravir plus lamivudine alone, and the patients who use this, if the viral load is less than 500 copies per mil and the patient doesn't have chronic hepatitis B, you can use these 2 drugs, dolutegravir plus lamivudine. Now, long ago, well, say about a year or 2 ago, when the initial studies showed that dolutegravir might have been associated with neural tube defects, all right? But because we have more data now, they found that there's no increased incidence of neural tube defects in patients with dolutegravir. So we don't have to rush to do the pregnancy test as before. Now, there's generic dolutegravir available. All the islands have it. of the islands, Antigua, Barbuda, St. Lucia, Jamaica, you know. Trinidad can't get it because dolutegravir is made by GlaxoSmithKline. And GlaxoSmithKline has a patent for dolutegravir until 2026. Of the islands, they have generic dolutegravir plus lamivudine plus tenofovir as one pill. Minimal side effects. Patients love it. One pill, they don't get any side effects. We can't get access to this because GSK forced the patent Trinidad as a high-income country. So we stuck with our efavirenz with all those neuropsychiatric side effects that I mentioned. Now, here's another one here, bictegravir plus tenofovir plus alafenamide plus M-tricycline. This is called Biktarvy. You might have seen Biktarvy advertised on TV. Now, Biktarvy is made by Gilead Pharmaceuticals. A month's supply of Biktarvy in the US costs $3,000 US. So, you know, we can't afford that. But what Gilead has done for third world countries, they have an access price. So they have actually, they bring Biktarvy into the third world countries at the cost of $80 US per bottle. So Trinidad recently, the Biktarvy was recently got onto the, well, I mean, it got a registration in Trinidad and Tobago. All right, so, but it's not on formulary as yet. So again, we don't have access to it as yet. So we still stuck with the efavirenz-based regimen with only neuropsychiatric side effects. Any questions? So because Biktarvy is available, and all the patients see it on TV, and they get it for 760 TT. That's what the massive distributors sell it to the patients. A lot of the patients decide, look, I can't take this efavirenz thing. I'll go spend the 760. I'm going to take Biktarvy. I don't have side effects, right? Only side effect, you might get a weight gain later on. Any questions? So we can't get dolutegravir, basically. And these are the preferred regimens. So in Trinidad, we have no preferred regimens on our formulary. Any questions from anybody? So recommended initial regimens in certain conditions, and you can see we have lots of regimens in certain conditions. All right. Raltegravir and elvitegravir are other integrase inhibitors, but they have lower genetic barriers to resistance, so they're not as good as dolutegravir and bictegravir. And then you have these protease inhibitors boosted with all the drug-drug interactions. I mean, not great, but we have to use these. So we use atazanavir and darunavir because we can't get the dolutegravir. Again, recommended in certain situations, and unfortunately, we stuck with our efavirenz here, plus tenofovir plus M-tricycline. So that's what we stuck with here. All right. Now, you all might have heard all the patients talking about these injectables. Probably saw it on TV and stuff. These are the injectables where you can get, instead of taking a pill every day, you can take an injection, you know, one in each buttock. So it's 2 injections, either once a month or twice a month, all right? So these long-acting injectables, or LAI, all right? Usually they're a combination of 2 drugs, an integrase inhibitor, cabotegravir, and an NNRTI called rilpivirine. And this was approved by the UN, right? This combination is indicated as a complete regimen, all right, in adults. So what you need to do is basically, patients would go on to a stable regimen, all right? And once you suppress your viral load for 3 to 6 months, all right, and you have no history of treatment failure or no suspected resistance, either carbotegravir or rilpivirine, then you could switch to the long-acting drug. So, you go on your regular antiretroviral therapy, suppress your viral load for 3 to 6 months, and then you can go on and switch. So you can get your long-acting injectables, one in each buttock, every month or every 2 months. So how they do this? Before they used to do a 1 month. So once your viral load is suppressed, you'll give a 1 month lead-in of oral carbotegravir with rilpivirine, all right, orally for a month. Now you realize you don't need to do this again, all right? You could probably jump straight into this here, all right? So on the last dose, on the last day of the oral lead-in, all right, they give injectable carbotegravir, all right, with injectable rilpivirine administered via separate intragluteal injections, all right, in each buttock as a loading dose, all right? Before they said you need the oral lead-in, but they're now saying they could jump to the loading dose. So once your viral load is suppressed for 3 to 6 months, you give a loading dose of injectable carbotegravir 600 milligrams and rilpivirine 900 milligrams. So there are 2 ways you can go from this. You can either continue this loading dose every 2 months, all right? Carbotegravir 600 milligrams and rilpivirine 600 milligrams, or you could reduce the dose and give carbotegravir 400 milligrams and rilpivirine 600 milligrams every month. Some people prefer the monthly injections, some people prefer the 2 monthly injections, but so those are the long-acting antiretroviral therapy that you heard about. Any questions on this? Not available in our part of the world yet, but some patients who are abroad, when they come back, they tell us, hey, doc, long-acting drugs, you know, I have to take my pill every day. But the problem is, you're saying you don't want to take a pill. Once somebody is virally suppressed, we normally give them a 3 to 6 months medication. So they have to come back to clinic for 3 to 6 months. These people have to go back to clinic every 1 to 2 months to get an injection, but they don't have to take a pill every day. So, I mean, you have to balance the risk and the benefits. Any questions? All right, good. So as I mentioned to you, once you start antiretroviral therapy, usually by about, 3, with the integrase inhibitors, we've seen the viral load suppressed from about 1 to 2 months. With the other drugs, usually by about 3 to 5 months, the viral load suppressed, undetectable, and the CD4 count goes up. All right. Now, these have these 90 targets. All right. UNAIDS had the strategy where they found that they want 90% of people living with HIV to know their status. So you had to go and test everybody out there. They want 90% of the people diagnosed with HIV to receive antiretroviral therapy, and then 90% of those who want antiretroviral therapy to be virally suppressed. All right? They were saying that if you get this, they would have eradicated HIV by 2020. Of course, 2020 come and gone. Most of the countries haven't reached this. So they have new targets now. They have the 95 targets now, where they say if 95% of the people know the status, 95% of those are antiretroviral therapy, and 95% of those who are on antiretroviral therapy are virally suppressed, you can eliminate HIV as a public health problem by 2030. They want to have 0 new infections by 2030. As I say, I'm happy that, this works. U equal to U, undetectable is untransmissible, but I mean, you have sexually transmitted diseases like gonorrhea and chlamydia, syphilis, and we could cure those, and we've never been able to eradicate them. So again, I'm hoping we could achieve this, but not too optimistic. So the takeaway points, I want you to take these away. with HIV medication now, HIV is now chronic disease with a life expectancy almost that of the non-HIV infected persons. U equal to U, meaning that somebody with a suppressed viral load does not transmit HIV to the sexual partners. All right. Any questions? I'm just gonna do a little bit about HIV in primary care, show a few pictures and we're done. Any questions so far? Great, so I'll just have a couple slides of HIV in primary care now. So over the past 2 decades, due to antiretroviral therapy, we have actually altered the natural history of HIV. There are less opportunistic infections, we have decreased mortality, all right? And patients now have a normal life expectancy. In our clinic, I work at MRF. Most of the deaths from the HIV patients are from non-HIV related causes. So they die from MIs, strokes, gunshot wounds, road traffic accidents, Not many of them die from HIV again, all right? But remember, I also told you that HIV infection also appears to increase the risk of non-AIDS related conditions, including cardiovascular disease, renal disease, liver disease, and malignancies. All right, and it was found that these and other common age-related diseases may occur more frequently and at a younger age than in HIV uninfected people. So, I mean, these non-age-related conditions may occur more frequently in the HIV positive persons and occur at a younger age. And some of these things are killing the patients, not the opportunistic infections or the. So in terms of optimal care of the HIV positive patient, all right? So you need to be able to evaluate a patient for their complications, all right? And you all do this, routine preventative care, So of course, all the usual, lifestyle habits you advise them about, smoking, exercise, reduce alcohol, all the things you all do in primary care, all right? All those are important in reducing the risk of MIs, liver disease, renal disease, etc. among the HIV positive patients, all right? So all the traditional primary prevention of the risk factors, we apply this for HIV patients. Some HIV patients may get hematologic, renal, and hepatic toxicity. ACT or zidovudine was associated with bone marrow suppression, tenofovir might be associated with renal disease. Some patients, HIV patients, may be co-infected with hepatitis B and hepatitis C, and some unfortunate ones may be co-infected with HIV, hepatitis B, and hepatitis C. So you need to evaluate your patients for these things, all right? Again, you're all accustomed to doing that in primary care. So again, you do your CBC, your renal function, your liver function, your lipids, etc., how you all do it in primary care, all right? For patients on antiretroviral therapy, frequent monitoring should be a bit more frequent, especially for some of the drug-associated toxicity. So we tend to do a CBC with DIF every 3 to 6 months, the basic chemistry. Initially, we do it at 2 to 8 weeks after starting antiretroviral therapy, and then every 3 to 6 months after. Again, we do a urine analysis following ART initiation, and then every 12 months after that, or every 6 months if they're on a tenofovir-based regimen. And again, we do liver function tests initially 2 to 8 weeks after starting an antiretroviral therapy, and then 3 to 6 months. We tend to do every 6 months, all these tests in our patients, all right? And if these patients have baseline abnormalities, and hepatic renal or bone marrow function, well, you need to do these tests more frequently. Again, you're accustomed doing this in primary care, but again, as I say, we tend to monitor these things at the MRF every 6 months. So again, you monitor the HIV patients in primary care for cardiovascular disease, some of the protease inhibitors on the back of you, maybe with this lipidemia, all right? And again, be aware of some of the drug interactions between the lipid-lowering drugs and the protease inhibitors, especially glucose intolerance and diabetes, hypertension, tobacco use. So, I mean, all the things you all monitor for in primary care, you do this, but if the patient is on tenofovir or protease inhibitors, again, you monitor them for premature bone loss. If they're on efavirenz, you monitor them for neuropsychiatric disorders, depression and suicide, and And again, if they're HIV infected, cervical cancer is an AIDS-defining condition, so you need to do your cervical pap smears, and some people do anal pap smears in the US. All right. Screen them for other sexually transmitted disease and tuberculosis, and of course, screen them for viral hepatitis and hepatitis A, B, and C. All right, any questions? I mean, you're all accustomed screening your patients in primary care, so there should be no big thing for you all. It's just a HIV infected, so, screen more for STIs and the viral hepatitis, in addition to all the other screening. Other primary care issues, if the patient has a CD4 count less than 200, they need to be on prophylaxis pneumocystis pneumonia, which is cotrimoxazole tablet, 1 double-strength tablet daily. All right. If the patient is on antiretroviral therapy, CD in primary care, you need to tell them, you need to maintain adherence so that they can maintain the viral suppression. U equal to U, they won't transmit HIV to their sexual partners. All right. And because the HIV infected, behavioral risk reduction counseling. As I mentioned in behavioral risk reduction counseling. So, because HIV in Trinidad and Tobago and over the world, U equal to U, nobody's scared of HIV. Again, we have antiretroviral therapy. We have PrEP. I'll mention PrEP-tail in a bit. I'll talk about it when I'm talking about PrEP. I'll talk about it, the risk reduction. All right. Food safety, again, in primary care, avoid raw eggs, salmonella, seafoods, hepatitis, undercooked meats and stuff, for toxoplasmosis, unpasteurized milk, Pet safety, especially the patient has a CD4 count less than 200. Somebody should be changing the cat litter and thing for them. Travel safety, travel safety because of COVID. You should be yellow fever vaccinated. I'll talk about vaccines in terms of HIV positive patients. Right, talking about immunization. So again, if a person has a CD4 count greater than 200, they don't have AIDS, and I mean, the following vaccines are recommended: the hepatitis B, which is a recombinant vaccine, HPV recombinant vaccine, influenza recombinant, I mean, pneumococcal vaccines, DTP, COVID. Live vaccines, note, are contraindicated in patients with CD4 counts less than 200. So we don't really like to give live vaccines in patients with CD4 counts less than 200. And I mean, if you may give the recombinant vaccines, and the patient has a CD4 count less than 200, because they're immune suppressed, they may not be able to mount a proper immune response to the vaccine. All right. But most of our patients got COVID vaccine, they got influenza vaccine, they get HPV, they get hepatitis B vaccine, pneumococcal vaccine, they have no problems with it. All right. In terms of the live vaccines now, the viral vaccines, MMR, all right. For patients with CD4 counts greater than 200, again, you administer the 2-dose MMR vaccine 1 month apart, you know. If they don't have evidence of immunity to measles, mumps, and rubella. Again, you all should probably know this from your primary care. Rather than giving the oral polio vaccine, which is a live vaccine, we tend to give the inactivated polio vaccine to patients with HIV. In terms of varicella, again, varicella is a live vaccine, so in patients with a CD4 count greater than 200, we give the 2-dose varicella vaccine 3 months apart, all right? Patients with CD4 count less than 200. Now, there's a combination measles, mumps, rubella, and varicella vaccine, all 4 in 1. This is contraindicated. We don't tend to give it in HIV patients. And the zoster vaccine, this used to be contraindicated because it was a live vaccine, but now there's a new vaccine. There's a recombinant vaccine called Shingrix vaccine. And this is recommended for all HIV positive patients 19 years and over. In primary care is recommended for people 50 years and over. All right, but for immunosuppressed patients, it's recommended if they are 19 years and older, they get a 2-dose recombinant Shingrix vaccine manufactured by GSK. All right, any questions on the vaccines? That live zoster vaccine, I don't think they make that again. Any questions? You're supposed to know all about vaccines and stuff. In terms of post-exposure prophylaxis, so if somebody, a healthcare worker, gets a needle stick injury, all right, and the person is HIV infected, all right, or you may come in contact some HIV infected blood splashes on you, or somebody having sex and the condom bursts and the patient not on antiretroviral therapy, you can get post-exposure prophylaxis, all right? And for healthcare workers, we usually consider HIV and hepatitis B, and all healthcare workers should have been vaccinated with hepatitis B. Now, in terms of risk of transmission from one exposure, you could see if you get a blood transfusion, a whole unit of blood, 93%. IV drug abuse, 0.63%. Oh, by the way, tell me, how does IV drug abuse transmit HIV? How come it's 0.63%, which is higher than a lot of the others, except receptive penile anal intercourse? How is HIV transmitted by IV drug abuse? Tell me what happens. Anybody? What do these drug addicts do when they inject the drugs?
It's not blood-to-blood transmission.
How is
Hi,
it
good night,
blood-to-blood? Yeah, go ahead. Yeah.
Hi, doctor. They share needles.
How they share the needles?
They'd
I know it's
use it
blood-to-blood
and then
transmission.
immediately pass it on to their friend.
They what? Let me hear say it.
They'd use it and then immediately pass it on to their friend.
How they use it? Let me hear. What they do exactly? Asking.
I guess they'll tourniquet their hand,
Yeah.
inject the needle, and then give the drugs and then take it out and give their
Yeah,
friend
but
it.
all your person. So how you know you're not vein?
Flashback.
Yeah, they pull back on the syringe. So you have a needle and syringe with heroin. You tourniquet the arm. You stick the needle and syringe with heroin, and heroin into the vein. You pull back, and you get blood in the syringe, and you inject. And that same bloody needle or blood in the syringe, you pull up more heroin, and somebody else uses it. Right? So that is why it's such a high risk. Needle stick injuries, you can see 0.23%, mucous membranes 0.09, receptive penile anal intercourse, no. Receptive anal intercourse, pretty high risk, 1.38. No surprises found in the gay man. Receptive vaginal intercourse, 0.08. Mother to baby, remember, say between 25 to 30%. And if you breastfeed, 14%. And compare this to hepatitis B and hepatitis C. All right, so hepatitis C, hepatitis B up to 40%, hepatitis C up to 3%. So they are much more infectious than HIV. Yeah? We have a vaccine for hepatitis B, and we can actually cure hepatitis C. You all know you can cure hepatitis C, right? Using direct acting antivirals. You all know that? Oh, yeah, reached that in the course yet. You know that, right? Nobody don't know that. We could cure hepatitis C now. With hepatitis C, unfortunately, if you got hepatitis C long ago, up to 80% of people used to go on to develop chronic liver disease. So hepatitis C is real bad news. Now, because we know the life cycle of the hepatitis C, they develop these direct acting antivirals, so it could cure hepatitis C in over 90-something percent cases. A 6 to 12 week course to cure it. But I'll leave that for your hepatologist to talk to you about. So somebody gets a needle stick injury, need to assess them, need to counsel them, write a prescription and follow up. So what you do, you clean the wounds with soap and water, or you flush your mucous membranes with water. There's no benefit of squeezing the wound or applying antiseptics or things like that, or applying bleach. As a matter of fact, they're thinking if you do all that, you might, the inflammatory cells might migrate to the area, and some of these have the receptors for HIV to bind to. So, all right, so don't go squeezing and putting bleach and things, just wash with soap and water. And the post-exposure prophylaxis should be started within hours. I usually like to start it within 1 to 4 hours, but they give you up to 72 hours. All right, the sooner the better. So don't wait for 72 hours, have 72 hours. Try to start within, because you don't want the HIV to start binding to the receptors, the CD4 cells in your body, all right? And you usually give a 3-drug combination for 28 days. So the 3-drug combination we give is tenofovir plus M-tricytabine plus raltegravir. Raltegravir is an integrase inhibitor, and this combination here has minimal side effects. All right, raltegravir is fairly expensive, so in the hospital, you all will probably get tenofovir plus M-tricytabine plus lopinavir, ritonavir, and this has horrible GI side effects. So unfortunately, most of the healthcare workers tend to get this. But usually the doctors come by us and quietly give them this one so they don't get any side effects, all right? But if you go to the healthcare system, they tend to give you this one. And lopinavir, ritonavir have hard side effects. You need to take the medication for 28 days, all right? And we usually monitor the healthcare worker. We do an HIV screening test at baseline to make sure you're not HIV infected coming into the situation. All right. We do your liver function, kidney function, and CBC, pregnancy in females. Repeat that 2 weeks. And then we tend to do a viral load probably at 6 weeks. So you can do HIV antibody test. All right. PrEP, pre-exposure prophylaxis. Pre-exposure prophylaxis means you're giving an uninfected person antiretroviral therapy. They take this every day, all right, which is a combination of tenofovir and M-tricytabine. You have your antiretroviral therapy on board. So if you come in contact with HIV, it generally dramatically reduces the chance of getting HIV. So people who want to continue with high-risk behavior, they ask for PrEP. Unfortunately, the Minister of Health hasn't wrapped his head around PrEP yet, so he's getting there. So PrEP is not available in Trinidad yet, but it's one of the preventative methods. And, who gets PrEP? All right, high-risk people, so men who have sex with men, transgender people, people with STIs, people with quite a number of sexual partners, inconsistent condom use or commercial sex work, all right? So to give PrEP, they must be HIV negative. Remember, you're given 2 drugs, so you must have a documented HIV negative test and no signs of acute infection, normal renal function, and then we give it. And then we followed them up for 3 months and we repeat the HIV test. We found a lot of patients getting STIs because they ain't using condoms. They ain't getting HIV, they're getting all the STIs, all right? So you try to counsel them to tell them, you do your prep, still use condoms because you're at risk of getting the things, all right? All right, let me give you this story quickly and then I'll finish off now. So in terms of prep, so a lot of the MSM, they ask for prep, but they actually get prep on the internet or they go about and get prep. Now, they have all these sex parties in Trinidad. You all know that, huh? Every week, there's a sex party for the men who have sex with men. So there might be one in Marabella, one in Valsine, one in Diego Martin, you know. Every week there's a sex party. So there's a WhatsApp group. They send out their WhatsApp things, all right? You go to these parties. You go, pay entrance fee, must say $100. You get free drinks, you know. You have condoms, you have lube, and you can have sex with whoever you want. All right. That's basically it. Now, I'll just give a quick little story. So one of these guys who attended these sex parties, he was actually HIV negative. He had a partner came to see me to say, Doc, you know, we attended these sex parties at one time. Treatment for STIs, all right? So two of them came in. One of them had severe, he had perianal pain with perianal ulcers. So I said, well, I thought he had herpes, all right? And the other one, he was totally asymptomatic. And he said, well, you know, I'll just want to screen for a STI screen. All right, so I said, well, you know, you could probably do an HIV test and do a syphilis test, you know. He had no discharge or nothing, you know. Anyway, the next day, he sent me a photo and said, Doc, look, I have this lesion come out of my penis. And I said, wow, this looks kind of funny. You know, it was umbilicated. I said, but you know, this don't look like herpes at all. Totally painless. I said, strange for syphilis, because syphilis gives painless ulcers. So this was like a Saturday he sent this to me. Or Sunday, sorry, Sunday. So I tell him, well, if it send me unexpected the following day. So he sent me a picture the Monday, it got a little bigger. And it really looks strange. So I say, you know what? Come in to CB. So my mind start thinking, what do you think I'm thinking about?
Monkeypox?
Yeah, so I thinking monkeypox. I said, this thing umbilicate looking strange. So he came in to me and said, by the way, any of your sex partners have any of these lesions, anything on the hands and the feet, you know? Let me know when they come in now. So he came in with a strange lesion. Then he showed me, he said, Doc, you know, he asked me about my sex partners. And look, they have these pustules on the hands. So that's when I realized this man had monkeypox. All right? He alone came, and the partner who had the perianal ulcers, he also had monkeypox. So I swabbed him, and that was the first case of monkeypox in Trinidad. All right? Then about 2 hours later, one of the doctors from QPCC called me and said, Doc, I mean, I have a patient with a strange rash. You know, he have lesions on the hands and he have a perianal ulcer. So I saw him, and he had the same pustules on the hands. And he had a pustule on the chest too. So I swabbed the perianal lesion, swabbed the chest, and he was the second case. All right, but the problem is, even though quite a few of them had monkeypox, the sex partners didn't get tested because they say, okay, well, what are you doing for me? You know, so all of them decided to isolate at home. And those were the ones who actually told me about all the sex parties they were having. And during this 21-day isolation, he's saying, Doc, though we have monkeypox, look, they still have no, he sent me all the flyers for sex parties, you know. So anyway, the county medical officer helped, all right. They made sure these patients isolated. make sure the contacts were in quarantine. They started to give the vaccines, I think, to they had the monkeypox vaccine. They wanted to give it to healthcare workers and the partners. They seem to have done a good job with the monkeypox again. All right. All right, just to show you quickly now, finishing up now. What is this?
Oral
Oral
candidiasis.
candidiasis.
And I treat oral candidiasis.
You can use clotrimazole, oral nystatin, or fluconazole.
Fluconazole is the drug of choice because it's so extensive. You want to use systemic. So fluconazole or itraconazole. What is this? Look at the area, it'll tell you the diagnosis. The anatomy tells you the diagnosis. What is that? Where is it located?
Angular stomatitis.
Yes, angular stomatitis, secondary to what? Candida. Look at the angular stomatitis, secondary anemia. There's angular stomatitis, secondary to candida. What is this? You get these white corrugated plaques at the infralateral surface of the tongue.
That's hairy cell leukoplakia.
Yeah, oral hairy leukoplakia caused by what? Epstein-Barr virus. Oral hairy leukoplakia caused by Epstein-Barr virus. Painful ulcerations of the lips. You all get this. What is this? Easy primary care diagnosis. Lips, gums. Yeah, after stomatitis. More common, I mean, in HIV patients, but everybody gets it. Usually trauma, you bite your lip, you toothbrush at your gum, you know. Topical steroid on it, you know, tends to help. If it's bad, I can give a dose of oral prednisolone, you know, but topical steroid works quite well. Usually it heals in 7 to 10 days. You get this scaly hypopigmented rash involving the nasolabial areas, scaly erythema and hypopigmentation here. What is this?
Seborrheic dermatitis.
Yep, seborrheic dermatitis caused by what? Organism.
Malassezia.
Excellent. And where does seborrheic dermatitis affect again besides the face?
The
Where you
eyebrows.
tend to get it? Huh?
You said besides the face, I said eyebrows.
The where? I don't know.
Back and shoulders? No.
Not back and shoulders. Where again?
Scalp and ears.
Yeah, scalp and ear. So that dandruff you think you get in the scalp. So how you treat seborrheic dermatitis? Comes from the scalp.
Ketoconazole shampoo.
Yeah, so use all the anti-dandruff shampoo. Ketoconazole, Head and Shoulders, which is zinc perithione, Selsun Blue, which is selenium sulfide. All right. And then for the skin, you could treat with a topical antifungal or topical corticosteroid. All right. Works quite well for seborrheic dermatitis. Comes and goes, stress makes it worse. What is this? Here you're seeing it and the coming out from the groin area. Also see it on the thigh here. You can see a raised border with all skin on the edge. What is that?
Tinea cruris.
Yep, tinea cruris and tinea corporis, you know, they sweat a lot. So again, how you treat your, what tinea organisms cause this tinea? The dermatophyte organisms cause it. So again, you treat with, you know, terbinafine, topically, clotrimazole, miconazole. That groin area with the sweating, you know, difficult to treat. Again, you can see same thing here. Scale at the edge, you scrape it, put it on a microscope with potassium hydroxide to see the hyphae and the spores. This person was treating the forearm here with a topical steroid, so it's called tinea incognito. Changes the thing of it a little bit. But tinea corporis, all right, so it's so extensive, terbinafine orally might work quite well. All right. What is this one called? Between the 4th and 5th toes? You want to common, this in common in primary care.
Tinea pedis.
Okay. Yep, tinea pedis. All right, and what do you need? What the trainees call it?
We call it toe jam or athlete's foot.
Athlete's foot, right, good. Again, another difficult condition to treat, you know, because your foot always in shoes and socks and sweaty. Again, you can try the different antifungals. Some people try the liquid form of the antifungals, you know. Some people put the spacers between the toes, you know, what you all female use, you know, and put the antifungals to be tight on the sleeping. Difficult to treat tinea pedis. All right, this patient has two conditions here. You can see what you see on the dorsum of the fingers. And what you
You
see
see
on
some
the nails.
psoriasis.
Psoriasis.
Yeah, so you see scaling on the dorsum of the fingers. And you see an involvement of the 5 of 6 nails. This nail is good. So patient has tinea unguium and tinea manum. All right, HIV patient. So tinea. All right. Scaling on the dorsum of the fingers. Tinea manum. Tinea of the nails also. Again, tinea of the nails, you have to use oral therapy, yeah? So terbinafine for 6 weeks. All right, this little child presented with this lesion here. You see, tell me what's happened with the lesion. All right, and see if you can come up with the diagnosis. So what's happening with the lesions? What's the scene with the lesions here? There's a term in dermatology that you're seeing here.
Satellite lesions.
Linear tracking. Linear tracking.
Linear tracking, or what's that called?
Scabies.
No, linear tracking is called what in
Hobner's
dermatology? The what?
Hobner's phenomenon.
Yeah, the Kebner's phenomenon. K-O-E-B-N-E-R. All right, and what's the diagnosis? May be difficult to get. I doubt you all will get this. This plain or flat warts. So where did this poor child get plain or flat warts from?
No.
You know, somebody is interfering with this child. Anyway. So Kebner's phenomenon, the linear tracking, and plain or flat warts. What is this?
HPV.
Yep. Condylobata acuminata, genital warts, HPV. All right. Patient had a large one. This was HPV. This was genital wart. And I send them to the surgeon to debug this, you know. Anal wart, HPV. And these are usually caused by HPV 6 and 11. So that vaccine you get prevents 90% of warts. The vaccine is 6, 11, 16, and 18. That's a 4-valent vaccine. And remember I told you this condition is an AIDS-defining condition. What is this?
Anal.
AIDS associated cancer. This anal cancer, squamous cell carcinoma of the anus. I'm tell you, it's a 50% risk in HIV patients. I see 1 or 2 every year. I have to send them for chemo and radiotherapy. Look, another one, squamous cell carcinoma of the anus. These lesions are skin colored with central umbilication.
Molluscum.
They look more like these, skin colored with central umbilication. What is this?
Molluscum.
Yeah, molluscum contagiosum caused by the molluscum contagiosum virus. Patient presents with painful vesicles. That's from ulcers. Painful vesicles are from ulcers. Where's that?
Genital
Herpes.
herpes.
Right. Which type?
It doesn't matter anymore.
Yep, it doesn't. Actually, that's a trick question. Right. Doesn't matter anymore. You can get, but strange enough, you get herpes 1 and 2 below the waist. All right. Above the waist is mostly herpes 1, very rarely herpes 2, but they don't matter anymore. All right. So herpes 1 and 2. Vesicles, all right. Form ulcers. And the herpes virus goes into the sensory ganglion, remain dormant, and can reactivate later on. All right. You all shouldn't see this condition You've seen vesicles, pustules, papules, all stages.
Varicella, chickenpox.
Yep, varicella, excellent. All right, you all shouldn't see this condition because people should be vaccinated. Chickenpox is mild in children, moderate to severe. Adults get covered with it, so vaccinate. So this adult was HIV infected. She was covered, and it causes scarring. She was pregnant, so we treated the HIV. Varicella could go across to the fetus. We treated the varicella, and the baby was over. All right. Vesicles are on an erythematous base with pain.
Shingles.
Goes.
Yep, following a dermatome, zoster. See it here following the dermatome. Remember, we have the shing. Well, it's not available. Yes, it should soon be available. The shingles vaccine. All right, for persons. What happens as it get older, remember, is a herpes virus goes into the sensory ganglion, remain dormant. And what happens as you get older, the immune, the cell-mediated immunity to varicella wanes with time, and then it can reactivate as zoster. So you need the vaccine when you're over the age of 50, or if you immunosuppress over the age of 19. All right. Now, zoster is associated with severe postherpetic neuralgia, so severe pain. And the pain can persist even when the lesions heal up. I found pregabalin to work okay for the pain. That's Lyrica, but I mean, sometimes nothing helps with the pain. All right. This patient presents with these fleshy growths, nodules, swelling of the lower limb, purple papules and purple plaques, all of them in the same condition. Any idea? I'll show you a few of them.
Lichen planus.
Same condition, purple plaques on the lower limb.
Kaposi sarcoma.
Kaposi's
Yeah,
sarcoma.
Kaposi sarcoma. Again, purple plaques on the trunk, Kaposi sarcoma. Yeah, this plaque, reddish purple plaque on the tongue, Kaposi sarcoma. Human herpes virus 8. If it's a cancer, you have to stage it. I actually treated this guy here with a tongue with antiretrovirals, and this actually resolved. But again, most of them don't. Could affect the GI tract and the pulmonary tract, you know? Patient presents with a discharge coming to the end. What's this?
Gonorrhea.
Urethral discharge. Give me a differential diagnosis of a urethral discharge.
Gonorrhea or chlamydia.
Right. Gonorrhea, chlamydia. Nowadays, we get mycoplasma, genitalium, and ureaplasma. All right. So what you do with the discharge? You have this discharge. What do you do with it to diagnose gonorrhea?
A penile swab.
Yeah. And what you look for?
You would look for the diplococci.
Gram-negative diplococci. Excellent. So this patient have gonorrhea. All right, but we also had nucleic acid amplification tests. He had gonorrhea and chlamydia. All right, we couldn't diagnose chlamydia except by nucleic acid amplification. How do you treat gonorrhea?
Doxycycline.
Nope, gonorrhea. Now gonorrhea is becoming a super blood bug, getting resistant to most things.
Rocafen.
The penicillin.
Ceftriaxone is a drug of choice. Penicillin, nah. Penicillin won't touch gonorrhea. Ceftriaxone is a drug of choice. And to treat the chlamydia, you can use doxycycline 100 milligrams twice a day for a week, or azithromycin 1 start. Patient has painless lesion on the penis. What are you thinking about?
Syphilis.
And then you see this.
That is secondary syphilis.
Secondary.
Yep, secondary syphilis. Palms and soles, secondary syphilis. How do you treat syphilis? Secondary syphilis.
Penicillin.
Yep, long-acting penicillin, benzathine penicillin G. 2.4 mega units, all right? Patient presents with this abscess in the groin here. And there's a little thing in the middle here. What is that?
LGV.
LGV, lymphogranuloma venereum, caused by chlamydia trachomatis L1, L2, and L3, and there's a groove sign here. See the groove sign in the middle there? Treatment, doxycycline 100 milligrams twice a day for 3 weeks. This patient took many antiretroviral drugs and developed these target-like lesions on the hands. What does target lesions cause? And then these lesions on the lip, on the nose, on the eyes. What condition is this?
Stephen Johnson's.
Steven Johnson.
Yeah, well, rather than erythema multiforme. There are two forms of erythema multiforme. Erythema multiforme minor, which is palms and soles. Erythema multiforme major, palms, soles, and mucous membranes. All right, that you're like, well, you see Johnson kind of thing. All right. And this patient took an antiretroviral drug and developed this exfoliating rash. Patient took antiretroviral therapy and developed this thing here on the face. What's that? Coming to the end. What you seeing happening there?
It looks like
Is
muscle
face normal or
wasting.
not normal?
Not normal.
Why not normal?
Lipodystrophy.
Excellent. He has wasting. So some of the old antiretroviral drugs used to cause lipodystrophy. Lipodystrophy is basically a redistribution of fat, where you get atrophy in certain areas. All right. So you get atrophy in the face, the arms, and the buttocks, and hypertrophy in the breast, sorry, the supraclavicular area and the abdomen. All right. So this combination of lipoatrophy and lipohypertrophy is called lipodystrophy. So many drugs used to cause it. This man came in worried about his lipoatrophy, but he also had something on him. You see anything else on him? I said, boss, you have something on your face. He said, boy, but this thing, nothing. So anytime patient have a strange asymptomatic rash, you need to screen them for something. What would you screen them for? Any asymptomatic rash in a patient.
Syphilis.
He wasn't worried about the rash because it's asymptomatic. We're seeing the thing on the chin here, right? Seeing the lesions?
HIV.
Huh?
You're worried about malignancy?
Nah, say boss, I think you have syphilis.
HIV.
Any patient coming with a asymptomatic rash, screen them for syphilis. VDRL 1 in 256 TPP reactive, treat him with penicillin, cure that. All right? But he was more worried about his lipoatrophy, so we gave him some fillers to kind of fill up there. All right, so any questions, folks? Took you all slightly over the 2 hours, but hope you all enjoyed it. Any questions? Somehow I think I missed some of it, you know. I was supposed to do TV and all these kind of things, but I don't know. Somehow I missed some of it, but anyway. All right, any questions? We good? So I'll go down, I'll send you all the slides. I'll send off all the slides, all right? Great. Thanks a lot, folks. You all were great, great participation from you all. All right, I'll send you the slides, so don't worry. See you
Thank you.
all.
Yeah,
Thank you
bye-bye.
very